Okay. So let's see the next question. So our next question is an abdominal mass is based demonstrated in case of congenital hypertrophic pyloric stenosis by the option A in palpation over the epigastrium, option B in the left hypochondrium, option C right iliac fossa, option D is the during feeding. So let's see few things regarding the CHPS and let's try to understand. So your CHPS basically stands for congenital hypertrophic pyloric stenosis. So your congenital term itself basically suggesting towards that there is a condition that typically seen in case of infant, and the infant of around 2 to 6 weeks old. And what exactly happens in such cases is that there is a pyloric muscle that get hypertrophied, and as a result of that there is a formation of the gastric outflow obstruction. Now you need to understand why this pyloric muscle getting hypertrophied. So there is a congenital absence of the enosynthase, or let's say there is a defective enosynthase or the nitric oxide synthase is there, and as a result of that your patient pyloric muscle is unable to relax in such cases. So as a result of failure of the relaxation of the pyloric muscle, that will eventually leads to development of the gastric outlet obstruction. Now you need to understand what is the clinical features here. So obviously the patient will typically comes to you, or the mother will tell you regarding there is a projectile vomiting, and on asking they will say yes, it is a non-bilious vomiting, and that typically happens after the feeding. So there is a projectile non-bilious vomiting. So you can see that in this image, right? So our bile duct basically drain into the second part of the duodenum, right? So as the site of the obstruction basically proximal to second part of the duodenum, obviously this is not going to show or present it to us with a bilious vomiting, right? Do you guys able to get my point? Now the patient will typically present it to you with a palpable olive shaped lump. So there is a palpable olive shaped lump or mass that is typically seen in the right upper quadrant, right? So that is typically seen in the right upper quadrant. Okay, or sometime they may be seen in the epigastric region too, and obviously there is a visible gastric peristalsis that is supposed to be seen from left to right. Okay, so there is a visible peristalsis that has been seen from the left to right, and as a result of repeated projectile vomiting, the patient will eventually present it to you with a dehydration and subsequent weight. Now the most important point, like the examiner's favorite point, is the metabolic consequences. You need to understand these things very much clearly, right? So what exactly happens? The patient basically presented to you with the repeated episodes of vomiting. So as there is a obstruction at the level of the pylorus, so the content of the vomiting mostly will be what? Mostly the acidic content or the stomach content. So so there is a lots of the HCl that is getting lost. So as a result of that, there is a hypochloremic, and as there is a loss of the acid, so there is a alkalosis. So there is a hypochloremic metabolic alkalosis has been there. Okay. Now, as a result of the alkalosis, our body's normal mechanism is like it will eventually bind with the calcium. Okay. So that will leads to development of the hypocalcemia, and in some cases that will eventually leads to development of tetany as well. Now, as there is a repeated episodes of the vomiting that leads to dehydration, that is the number one, and there is a alkalosis has been there, that will leads to activation of the RAS system. Okay, angiotensin aldosterone system. So as a result of that, there is a excessive sodium reabsorption and there is a excessive potassium loss. So as a result of that, that potassium loss is basically eventually reflected to as a hypokalemia. So the patient will also present it to you with the features of hypokalemia, and eventually that hypokalemia again worsen the vomiting and the dehydration status or overall general status of the patient. Now as a result of that, there also seems to be presented with a paradoxical aciduria. Paradoxical aciduria in that case. Okay, so how to diagnose such patients? So your clinical examination obviously remains one of the cornerstone for the diagnosis of such patient. And here the patient typically present with a olive shaped mass, which basically best appreciated during the feeding. Okay, so that mass you are able to palpate, that is typically appreciable after the feeding. Okay, so in most of the cases while examining the patient, we often give the patient a test food, like a test feeding has been given to the patient. Often examining a patient with a CHPS, we often give the advice of test feeding while palpating such patient. Okay, so there is a appearance of the olive shaped mass, and that is best appreciated during the feeding. But your ultrasound remain gold standard, and in case of ultrasound obviously you are able to appreciate that. You can easily see that, like there is a hypoechoic thickened pyloric musculature that has been marked in the eolo, right? And obviously there is a central hyperechoic mucosa that is basically blue in nature, and these two things is basically known as the cervix sign. Okay, now regarding the diagnosis, while doing the ultrasound, we basically try to see two specific criteria. One is the pyloric muscle thickness. So regarding the pyloric muscle thickness, like the thickness more than 3 millimeter is strongly suggestive of the disease, and again the length of the pylorus, while it is more than 14 millimeter, again it will suggest us towards the diagnosis. Now regarding the management of such patient, obviously you must first of all correct the dehydration status of the patient, then correct the electrolyte as soon as possible. Then only after correcting the fluid imbalance and the electrolyte, then you can go for the definitive management, which is the Ramstedt pyloromyotomy. So here what we basically do, there is a longitudinal incision along the pylorus muscle has been given, and as a result of that there is a bulging out of the mucosa that happens, and then we just resuture it, right? So this is how a patient with a CHPS has been treated. Now let's see the question again, right? Again, so here the question they ask is that there is abdominal mass, and that is best demonstrated in congenital hypertrophic pyloric stenosis is by, obviously it's basically best demonstrated after test feeding or after feeding. So your answer would be simply option D. You just here try to search your answer, or try to search the word during feeding, like this. Okay, there is no need to look for the other options here. Okay, do you guys able to get my point? Yes.